once again, I really appreciate and I really oblige to the organizer for the nice kind invitation. And my presentation on ovarian cancer, particularly that is a very controversial topic and throughout the world. And my topic is, does NACT reduce the overall burden in advanced epithelial ovarian cancer despite of increasing the CRS, or I mean the cytoactive rate? So kindly change my slide. Next. So that I'll go through quickly on this introduction and treatment option and what is the conventional upfront versus NACT. That does NACT really reduce the overall burden? And I'll discuss my study also and review of literature, and then thereby the decision making conclusion. We all know that ovarian cancer is the most lethal gynecological cancer, and that incidence is increasing day by day. And you all know that how much the survival despite of so much multimodality treatment. So there is a grave prognosis is there. And we know that cytoaction in heavy burden disease can be complex, because most of the patient in anywhere in the world, that is more than 2/3 patients, like 67% or more. And particularly in my center, you see the tertiary oncology referral center. Here the presentation is more than 90% patient present with the advanced stages. So the question is, what to do like in such situation, that always in worldwide, if you see the literature, in worldwide, the upfront surgery followed by that systemic chemotherapy is the treatment of choice. But sometimes we cannot go for the upfront surgery, and then we have to do the neoadjuvant chemotherapy for downstage the disease, and thereby we go for the interval cytoactive surgery. So, but my question is that really that NACT, whatever we offer for the patients, really that reduce our burden. So that is my question, and that's all about my presentation. If you see that platinum also we are giving as neoadjuvant 3 to 6 cycle chemotherapy to downstage the disease. But interval cytoaction after neoadjuvant therapy is truly challenging for the surgeon. So that especially after 6 cycle of the chemotherapy. Next. So the primary CRS followed by the systemic chemotherapy is still the worldwide standard. There is no doubt about that. But NACT followed by the CRS, that is interval CRS, is one of the viable options when the primary CRS is not visible. But the question is, who is going to take the decision? So that's a matter. Like that, we all know that surgeon skill and experience makes 50% difference in survival. That is without any doubt. And NACT cannot be the alternative to the poor surgical skill. So that is repeating, I am repeating again, being a surgeon, NACT cannot be the alternative to the poor surgical skill. Next. So next slide, please. Next, please. So why upfront CRS even in advanced cancer? That is the main question, because we all know that patient presents with the advanced stages. Despite of that, why we need that cytoactive surgery? Why we try to do the cytoactive surgery? That is the question, because we all know after removal of the cancer, particularly chemotherapy acts much more better, because there are the skin implants are there that is highly sensitive to the chemo, and removal of the mass in specific sites such as that causing the bowel obstruction or improve nutritional status and immunological status also. So that removal of the mass is important. NACT may delay the debulking surgery, or you can say the cytoactive surgery, thereby, and particularly it causes the desmoplastic reaction, and that may cause the surgery difficult, and the clearance of all the malignant tissue, you can say, and especially the cells are much more difficult. So that is next slide, please. So why upfront? Still, we maintain the theory of upfront CRS is that is very logical. NACT may lead to chemo resistance, because you all know that all the cases when we offer to the chemotherapy to the patient, that 80% may be responsive and 20% may not respond. There is chance of clone of resistance development is there. And if you see this literature, if you say in high-grade serous cancer, what is the recurrence rate? That is 80 to 90% in 5 years. Means almost every patient is presenting again with the recurrence, and especially after neoadjuvant chemotherapy. So a meta-analysis found a negative association between the overall survival and number of NACT. So that is already established on that. On the other hand, the upfront CRS reduces the tumor bulk and the number of chemo cancer cells, thereby chance of development of cancer resistance is less. So that's why most probably that is till date the standard worldwide, the upfront surgery. Please next. So NACT may be preferable when. So suppose few cases you there, I already discussed about that, when the patient is presented with the very advanced stages. So then you see the maximum different vital organs are involved like this. And when we are unable to do the cytoactive surgery, then there comes the role of NACT. So that better to do something for that NACT may improve the patient performance status also. It complete the cytoaction, and if you see the literature, if you see after NACT, the cytoaction rate is much more higher than upfront CRS, and that is obvious thing is there. But that is very important thing to understand when to go for the neoadjuvant chemotherapy. Next. So in advantage of NACT, if you see the initiation of the chemotherapy is easier procedure than the surgery. So disease is high, so it would be easier for the anybody like prefer the NACT, and thereby the disease burden will be less, and then the surgery will be relatively easier for the surgeon. But it is really easier. That is my question. So by the time of the surgery, patient PS could be improved, like definitely with the NACT, tumor will be downstage, interval CRS takes also slightly less time, and slightly we know the blood loss is less. But when we are convinced in any system, like that is a human nature, when we are convinced which is suitable for us, we usually go for that. But next please. So this is the trial, different trials are there. We all know the URTC trial, CORAS trial, GOG 0602 trial, and Scorpion trial are there. That is that NACT versus upfront surgery. And all trial shows there is no median PFS difference and median survival also difference. But in upfront cases, there is longer time for the surgery. And there also, you all know the blood loss is much more higher. The chance of thrombosis also there. Means the acute perioperative morbidity is much more higher in all the trial. So that is not inferior trial. Like you can do the go for the NACT, and that is non-inferior to the upfront surgery. They have mentioned all these trials. Next, please. So why not NACT is still not standard? Suppose there are so many trials, and despite of that, why NACT is not still that standard? So chance of recurrence, I told already, the more after NACT, and that I already mentioned 80 to 90% the 5 years recurrence rate as per the literature. So malignant tissue may be left behind and inadvertently because of the desmoplastic reaction. We cannot get the proper plane after the neoadjuvant chemotherapy. A development of the clone of resistance also there. And apart from this, NACT enhances the mutation of the that penetrant, high penetrance genes also. What happens? They increase the mutation of the high penetrance genes, and that may cause the lead to the recurrence and early recurrence of the disease. And nerve sparing hysterectomy, that question of these, although today in the present era, we always talk about the quality of life. You all know the quality of life is much more important than life itself. So, but that NACT, I don't know how much that improves the quality, because you cannot do the nerve sparing surgery also after the NACT. That's a very difficult job after NACT. And exposure to chemotherapy has the multisystemic implications also due to its toxicity to the healthy tissues, leading to complication during anesthesia too, as well as in the postoperative period. Next. Next, please. So does interval CRS a challenge for a surgeon? So that is my question, and definitely the surgery seems easier for a surgeon. For that, why everybody trying to go for the whenever is some borderline sort of thing is there, or some advanced disease, upper abdominal disease burden. Usually we go for this NACT, but really it seems easier after NACT. But constant oozing, one of the important issue after that NACT when you do the interval cytoactive surgery. There is capillary oozing sort of thing, and you cannot get the proper plane to do the surgery. Apart from anesthetic complication, already I mentioned. Next. Next, please. So what's about our study? We did one study as a whole, that is the post-chemotherapy cytoactive surgery. That should be considered as an unique entity. I mentioned in that, and that is mandating special surgical skill and experience. So supposing you are really doing the proper job, if you really want to do the proper job, so we should be skillful about that to perform this kind of surgery after especially NACT. In our study, we compare both the groups, interval cytoactive and followed by the upfront CRS, and we see the perioperative and cervical outcomes also. So we describe how to tackle the challenge also in our study and how to go step-by-step approach. And we did around 195 patients in upfront and 106 patients in interval setting. And we firmly believe that if one could perform the interval CRS, they can easily perform that upfront surgery. Next, please. Next. So, it's a clinical comparative study we do, and we have taken total. I already mentioned the patient in 95% for the upfront surgery, 106 patient for the interval surgery from 2014 to December 2020, and we have made an audit in the computerized database and ovarian cancer audit base, and we included all the patients of the advanced stages only, because in FIGO stage 3 and 4A who underwent CRS, and excluded the cases with incomplete entered data. So next, please. So this is our methodology. Like, we just have a clinical audit, and this is a prospectively maintained database and comparing upfront versus interval, intraoperative and immediate postoperative outcomes. We also mentioned. We also compared in terms of both perioperative and survival outcomes in our study. Please, next. So this is our result. If you say we have an exposure, we have performed around 506 patients, but from 2014 to 2020, but we have included only here 95 patients for the upfront surgery, and for NACT, and 106 patients for the NACT, and 95 patients for upfront surgery. And we have performed also in such a situation. We already mentioned the quality of life is very important. We have done also the nerve sparing hysterectomy also in few patients, and that is not less, that is 29% patient, because we all know that in upfront setting that is very easier, but in after NACT it's a very difficult job to do the nerve sparing surgery. In nerve sparing surgery more in upfront, that is our cases, that is 69% versus 42% in case of after interval site reaction. So this is our results, perioperative outcomes in terms of less extensive surgical procedure, bowel dissection, rates, blood transfusion. So all the things within 30 days are better in the definitely in NACT group, slightly better, but that in terms of blood loss or the timing of the surgery, length of the surgery. But these are all not statistically significant for us. But the completeness of surgery is an issue, and development of resistance of clone of chemotherapy causing the more relapse that we have seen in our study also. Thereby the compromised survival, which is reflected in our study in interval groups in the DFS, if you see, the DFS in upfront is only 44 months, whereas in interval that is 38 months. Next slide, please. So this is the curve here. We can see that in DFS difference in upfront and interval groups, that is 44 months versus 38 months, and that is p-value is also significant. Next, please. So this is also, we have just calculated our survival also. If you see that median survival in upfront CRS group, that is 64 months, and in NACT that is 47 months. So if you see the 5 years overall survival in upfront CRS group is 53%, whereas NACT is 42%, and the p-value is significant in this. So we see there here both the PFS and both the overall survival, 5-year survival, median survival also better in upfront group in our study. Next. So this is if you just go through not our study only, because if you go through the literature, if you see the literature worldwide, and if you see the one good important paper of Annals of Surgical Oncology, if you see the timing and pattern of recurrence in ovarian cancer patient with high tumor dissemination treated with primary debulking versus neoadjuvant therapy, they have a nice paper in Annals of Surgical Oncology. So next, please. So in this paper, if you see, they compare to this also the primary primary cytoactive surgery versus interval cytoactive surgery, and they have taken also 40%. That is very, that usually the upfront surgery, usually people do less. That 40% they have taken for the upfront surgery, and 135 were for the interval cytoactive surgery. Next, please. So that is the results. They have seen this in this paper, the median follow-up of 31 months, and they observed that around 50% recurrence in the upfront group, 50% recurrent. But if you see compare in the IDS group, that is 76%. So that is statistically also significant. In upfront group, the recurrence rate is very low, but if you post neoadjuvant in interval cytoaction, that is very high. Even duration of the primary platinum-free resistance also, that is one important issue. The platinum-free interval is shorter in interval group. If you see the shorter interval, because chance of recurrence is much more higher and more common in interval cytoactive groups. You just see the comparison here in the 13 versus 21 months, like the platinum-free interval. So that is also significant in this. And apart from this, if you see that a significant higher percentage of the patient in IDS group experience platinum resistance also, that is one important. Again, repeatedly I am telling, when you just offer the neoadjuvant chemotherapy, most of the patient that comes with the platinum resistance recurrence, that is also one of a challenge to treat, that is 35% versus only 5%. So this thing is there. How much the post NACT is just that compared to the PDA, compared to the primary surgery, is dangerous for us. So it causes the platinum resistant recurrence, and that is very early recurrence. Next, please. So this is the graph. If you see this, they demand that this is the better survival, better behavior of the recurrence pattern. They have mentioned in this paper all the advanced epithelial ovarian cancer patient. Even they see the peritoneal dissemination, the disease pattern, the disease recurrence is very much high and very much disseminated after recurrence of in interval cytoactive surgery. I mean, when you do the NACT and then we do the surgery, then when the recurrence occurs, that is a very dangerous kind of thing. One thing is there, that is the resistant platinum resistant recurrence, and the disease is very much disseminated. Next, please. So another one paper I can quote, that is one paper in the Frontiers Oncology. If you see the comparison of the survival between primary debulking versus neoadjuvant chemotherapy, they have also shown this. The next, please. So they have also compared in the primary both the NACT, and in conclusion they have mentioned NACT ovarian patient exhibited the inferior PFS, all the time compared to the primary cytoactive surgery. So the PFS is always better in upfront surgery. When you do the cytoactive surgery upfront, that is PFS is better. But OS they have they require more follow-up, they mentioned, but PFS definitely the improvement is there. So NACT cannot be arbitrarily denied while appropriate PDS is still a priority. So priority, even every paper, this paper, they say the priority is upfront surgery. So upfront means primary cytoactive surgery should be the priority. Next, please. So now one important thing, we people are doing the cytoactive surgery, and when you know that is the human nature, when you do something and we always say that we have done the good job, but that not always there. And till date, very unfortunately, there is no paper suggesting what is really optimal cytoactive surgery. So many people are doing, apart from the THBSO, they are doing infracolic omentectomy. Sometime I see being a surgeon in the tertiary care center, infra to infracolic omentectomy, they make the incision up to the umbilicus, and they take anyway the some part of this omentum. So they say I have done the cytoactive surgery, but that is not the cytoactive surgery. Cytoactive surgery is really extensive surgery, because if you see the pattern of recurrence, that is most common site of recurrence is the peritoneum, and as a rule in the advanced disease, we should remove the peritoneum, all this, if it is not like visible also. So apart from this, you have to do the total omentectomy, even the lesser omentectomy. You have to find out all the occult side, like retrohepatic side, all the sides, like pyloric, that portal side, even the enteropyloric side, ileocecal junction, rectosigmoid junction, all the sides are where the more prone to the deposits are more. So these are all occult side to be, you have to observe this thing, and if anything is there, you have to remove that thing. So the optimal cytoaction is like an extensive surgery, and you have to find out all the occult side and remove all kind of disease. Then you can say this is optimal cytoaction surgery is achieved. Next, please. So that is optimal cytoaction. We did what we all cases we know. We also found the retrohepatic bridge also, and that is connecting between the liver segment 3 and 4B, porta, gallbladder, supradiaphragmatic part also, hepatorenal pouch of Douglas, pyloric antrum, ileocecal junction, all the area to be also see this thing, because the area is more prone to have the deposits. And where the stagnation, all because why this kind of thing happens, because where the stagnation of the exfoliative cells are there, and hence the potential that these are the sites for the harboring of the occult disease, because these are the stagnant area what I mentioned this, and these are the dependent part of the body, And here, because this is a peritoneal surface malignancy, it goes and flows, and all the sites may involve with the disease. We have to be very meticulous about this before we just close this and before we consider ourselves that we have achieved the cytoactive surgery. Next, please. So these are our few photographs from our surgery. If you see that always better it is after, particularly this is the extraperitoneal approach, because the peritoneum is the common site of the recurrence. So always better to remove this thing, because in the peritoneum we routinely remove all the peritoneum, parietal peritoneum, pelvic and subdiaphragmatic peritoneum. Even if you see the disease in the Gleason capsule. And next slide, please. So we also remove the Gleason capsule. We do all cases in the lymph node dissection, particularly in the advanced stages. You can see this picture from our operative pictures, and we also do the nerve sparing RLND and nerve sparing PLND also. And this kind of picture should be there, the node to be removed, because we believe always the node is a part and parcel of the disease, and all advanced cases at least we should remove the lymph nodes. Next, please. So these are our cytoactive. We do the HIPEC also in the primary settings or interval settings, especially because there is much more evidence in interval settings, because we are generating our own data on the upfront settings. And if you see this picture from the left side, that is the Gleason capsule. I will remove the Gleason capsules because to remove the disease to achieve the CC0. Next, please. So these are our baseline characteristics of the patient. More or less, we compare all the patients in the age group and histology, grade, and stages. More or less comparable, and we compare both the groups and upfront surgery versus interval surgery. Next, please. So these are our the results. If I see the comparison of the perioperative outcomes, and if you see the perioperative complications, slightly in both the cases, suppose one is 15%, one is around 13%. In primary CRS, the complication is slightly higher, because you know that you have to do the extensive surgery. So readmission rate is also slightly higher in the primary CRS, that is 6.3%, whereas compared to the interval is 2.8%. Slight blood loss is more in upfront group, and rather these are not significant for the surgeon who is really regularly doing for a particularly especially for the surgical oncologist. So these are not so much significant in the two groups we observe in this. Next, please. So this is our self-analysis. From proper assessment and selection of the patient is the key. We all know the biology is the king and selection is the queen in every case, not only in ovarian cancer, any cancer, when you deal the cancer patient. So that is very important, and our techniques is very, very important, skill and technique, that is the prince and princess. And in borderline operable cases, in my view, in borderline operable cases, when you think about that, it is borderline, and suppose in high burden disease, in borderline, it may or may not be like this. That time one should assess and one should explore this to achieve the CRS, because we know the NACT, how much the NACT chance of recurrence rate is high. So patient with poor PS only, we can definitely go for the NACT. Otherwise, patient is performance strategy is good. High burden disease also, when it is borderline, when you feel like it may operable, may not operable. So you should at least explore to see. So because that is the more chance, that is the better way to tackle the disease. Having the stage 3 disease onwards means not like that patient is for should go undergo the chemotherapy 3 cycle. So the assessment is very, very important. So, but it should be on the protocol base, and not all cases we should do the NACT. So next slide, please. So this is our one paper, that is we decided from our study and our another study in which cases we should go for the NACT and which is not. So one is the important factor is there when the patient performance strategy is poor. Normally in ovarian cancer patient, when they presented in the advanced stages, so that time the patient may have the poor general condition. In that case, there is no doubt you should send for the NACT. Otherwise, suppose say patient age is much more, or patient is high burden disease, mesenteric root is involved, and small bowel involvement is there, liver parenchyma involvement is there, the splenic parenchyma involvement is there. You have to resect more than 1.5 meters of the intestine. So that time you have to think about that definitely. So then you should consider for the NACT. Otherwise, not like all cases, you should send for the NACT when the patient is diagnosed as 3C. Next, please. So this is from my presentation, my humble conclusion in this. Interval cytoactive surgery is always a surgical challenge without any doubt, because the surgical plane is very lack. We can leave behind the tumor tissue, but we are satisfied. We have done the surgery, but that may not be the complete surgery. So it appears to be easier, but than the upfront surgery. But practically, I don't believe that is easier surgery. It apparently that eases our burden. We feel like it reduces our burden to some extent, but in terms of perioperative outcomes, that is if you see this slightly, that is higher in case of upfront surgery. But if you compare this as your overall results, so that is you can just cope up with this burden, perioperative burden of this primary cytoreactive surgery. So we strongly oppose the random selection of the patient of stage 3C onwards. The patient should go for the NACT. So random selection we should strongly oppose from our study and our experience. NACT cannot be the compensatory to the post-surgical skill. That is my again and again I can say. So we should not, because I am not competent, I am not enough trained for this. So patient should go for the NACT. One should not do that. That harms the patient much more. And post-NACT interval series is inferior in terms of surgical satisfaction, completeness of surgery, recurrence rate, DFS, and overall survival. We already mentioned in that. We have shown the paper also in other papers, and the papers from the annals of surgery. Though immediate post-operative outcomes are slightly better, you can feel slightly better in compared to the primary cytoreactive surgery. Next, please. Next, please. So this is the choice. Now the choice is yours, because we people, whatever is convenient for us, we go for this usually. So, but that now the two choices in our hand to tackling the perioperative short-term challenges or long-term better outcomes for the patient with self-satisfaction. Because when you do the real job, you know you are satisfied. Because sometimes being a surgeon, we can any kind of argument we can do. There are so many papers are there, but self-satisfaction, unless you really achieve the complete site reaction, you cannot have this kind of satisfaction. So it like say I can compare with the happiness and pleasure. So we sometimes achieve the for the pleasure only. We do the small surgery, and we say this is we complete the cytoreactive surgery. So in case of post NACT, but you feel that is that kind of in compare we can compare between the happiness and pleasure. So it's a, I believe in upfront surgery is it can give you the happiness, but in the post NACT surgery give you the pleasure, but the not as a whole happiness. Not only you, your patient also. So choice is not in our hand. Choice is in the evidence only. Thank you very much for the patient sharing. Thank you everybody. Again, my greetings from New Delhi, India. Thank you very much. I am obliged.